Hola, I'm Jorge Ramos.
And I'm Paula Ramos.
And this is The Moment.
So today we're talking about something that we don't like to talk about as a society.
We don't want to talk about that, no.
My dad certainly hates talking about it, and this is the topic of death.
Yeah.
So the news of the week, Dad, is that New York just became the 14th jurisdiction to approve medical aid in dying. Mm-hmm. And yes, it's news, but more than anything, I think death, as much as you don't want to talk about it, Dad, death is a timeless, inevitable topic. No, we are all facing death in many ways. And this is one of the few times where I'm going to take off my hat as a journalist and I'm going to talk to all of you as a human, as a person that does have a very personal experience with the death with dignity movement. My grandfather, and you know this, Dad, my grandpa from my mom's side, over 2 years ago, was suffering from a very debilitating Parkinson's. And so he moved to Spain, he moved to Madrid, and euthanasia is legal in Spain. And so he went through a whole legal process to finally and successfully die through euthanasia. And he died surrounded by my mom, my grandmother, my uncle, my sister, and my cousin. And I think to this day, it's one of the most beautiful, painful, yes, but also beautiful experiences that I've ever had.
So we'll be talking about el abuelo Carlos. And Paula, as you know, this is an issue that also has brought so much grief to me. Just recently, just a few days ago, a very good friend of mine, a great reporter, decided to have an euthanasia in Colombia. And he told me, Jorge, no puedo más. I cannot do it anymore. Those were his words. And most members of his family were opposed to that. So this is a conversation that neither them or I wanted to have. But as you just said, Paola, we have to have it.
Yeah, and I want to be very clear for our listeners, euthanasia is not legal in the United States. What is legal here is medical aid in dying. And so today's episode is about really defining these complicated terms. It's about unpacking this incredibly taboo issue. And we have the honor of talking to the executive director and the CEO of the Death with Dignity movement. Her name is Dr. Peg Sandeen. And she's going to help both of us, but particularly you, Dad, really face the reality of death.
So our conversation with Dr. Sandeen when we come back. Regresamos.
Dr. Sandeen, welcome to The Moment. Thank you so much for joining us.
Oh, I am so happy to be here this morning.
You know, this topic that we're about to discuss is pretty personal to me. I think my father also has, I think for you too, Dad. And so we're very much looking forward to having this discussion with you. I also think that death around the world continues to be one of the most misunderstood topics. And so there's so much to unpack with you. But I do want to start with the news of the week, right? Which is the fact that New York just became the 14th jurisdiction to pass medical aid in dying. Governor Kathy Hochul just signed this new piece of legislation. And so I just want to take a few minutes to really start there and understand what this bill will allow terminally ill people in New York to opt for.
Yeah, we are so excited after working in New York for 10 years to have the governor finally ink the bill late on Friday afternoon. So indeed, we are very excited about this. The New York legislation is based in what I would call the U.S. model. It's very similar to all the 13 other states that have death with dignity in this country. And so when I'm talking about like the requirements for New York, they're the same in Oregon, Washington, Hawaii, all the other states that have the law in the United States. So the main things about death with dignity, they're really, when you think about it, there are four main things that are about it. It's for people who are terminally ill, so you have to be dying to access the law. Mm-hmm. It's about acting voluntarily, so no other person can be involved. It has to be the patient. It has to be that terminally ill person who has the ability to make and communicate decisions. So they're acting voluntarily. They have to be capable. Again, this concept that you have to be mentally competent to make a decision to request a prescription to hasten your death. And you have to self-administer it. So nobody else can do it for you. So it's really kind of like those are the 4 core principles. And what the New York law does is it allows a person, again, terminally ill, mentally competent, able to ingest the medication themselves, to request to a physician a prescription to hasten their death. And the law goes through a whole bunch of steps that the patient has to go through to qualify, and then the physician has to go through to write the prescription. And so those steps are all about, again, making sure that the person is mentally competent and is acting voluntarily to make the decision by themselves. So some of the things that the patient has to go through, they have to work with 2 physicians. So you have to have your original physician, and then you have to have a consulting physician. And they have to confirm that you are terminally ill. And how we define terminal illness in the law is you have to have a condition that will bring about your death in 6 months or less. And both physicians have to say that. So like the attending physician and the consulting physician. And then there is a mandatory mental health evaluation to make sure that there's nothing going on with you, like a very deep depression or dementia that would impair your ability to make this decision. So you have to go through that. And then there are waiting periods, and you have to do different types of requests. So you have to do an oral request. There has to be a recording. You have to do a written request. It has to be witnessed by people who aren't going to inherit from your estate. And so all of the steps, when you think about all of the steps that you have to go through as a patient to qualify, we're just making sure, again, that you are terminally ill, that you're mentally competent, and you're making the decision of your own accord.
So, Dr. Sandeen, who makes the final decision in all that complicated process? Who says it's going to be my decision?
It is the patient.
At
the patient
end.
At the very end. Now, the doctor. So there's a couple players here. The doctor have to determine that the patient qualifies, that meets all of those steps and all of those standards. And so the doctor has some amount of say in this because they have to write the prescription. But it is all up to the patient. And so in the very end, the patient could decide, goes through all the steps, gets the prescription, has it in hand, and decides, no, this is not for me, or I don't want to take the medication. So in the very end, it is that patient's choice.
From what you're describing, it seems like a long and arduous and strict process.
Yeah, it really is. And this is the complication about death with dignity, or one of the complications, is that from a legislator's perspective, or from, Governor Hochul's perspective, they're trying to pass a law that creates a right for a certain group of people, terminally ill people, but it protects everybody else, right? And so that's the legislative tension. Like, how do we create a bill that makes sure that if you're terminally ill, you can get through that process, but protects everybody else? And again, I call that a legislative tension, sort of like trying to make sure that we're not impeding access, putting too many steps in for someone who's dying. Like that's a lot of steps if you're dying. Mm-hmm. And that's the challenge is have we gone too far? Is the tension right? But that's the issue in every state that we consider.
So Dr. Sandeen, I still remember in the 1980s, all the controversy with Dr. Jack Kevorkian and assisted suicide. And I honestly, so many people are confused with the terms that I need your help with the definitions. What's the difference between dying with dignity, with assisted suicide, and euthanasia? Sometimes it's confusing just to understand the three different procedures.
Yeah. And I would also say that because it's confusing and because death is scary, our opponents like to really pressure people on this issue of the use of language because it can scare people into voting no. I think that is part of the challenge too, is not only don't we understand death or these terms are confusing, we don't use them very often, but our opponents weaponize the language to stop it in the legislature. So let's start with euthanasia. That is actually banned in every state in the United States. That is illegal. And what euthanasia would be is if a physician came to you and you said, please inject me with medication to end my life. So you have like you have an IV set up, someone else pushes the button, puts the medication in you, and you die. That's euthanasia. Some countries in the world permit that. For instance, Canada, other countries permit that. But in the United States, that language is prosecuted, or that behavior is prosecuted. So we don't not allow that. And again, that's the concept of self-administer, like the person has to do them for themselves. What we permit in the United States, if I would sort of like flip that on its head from euthanasia, is medical aid in dying, right? Or what we call death with dignity. And that is a process that, a physician and a patient follow that's codified into law. Like these are the steps in order to receive a prescription that I must ingest to hasten my own death, and I make the decision myself. That's medical aid in dying. Physician-assisted suicide, those sorts of language that we hear, again, that's sort of like our opponent's weaponized term that you hear much more often in a legislative environment than in a medical environment. There are times, or sometimes we do hear some criminal actions from physicians who might end a patient's life. They might, use a medication to inject them or something like that. And those are in criminal cases, and that's sometimes what we would call physician-assisted death or physician-assisted suicide, but that would be criminalized also.
So you would oppose what Dr. Kevorkian did many decades ago?
I was around when Dr. Kevorkian was doing this, and my mom was a hospice nurse at the time. And she was a proponent of his activities. She saw a lot of bad deaths. That was in the time of HIV deaths that were pretty bad, and she was a supporter. So I would say that Dr. Kevorkian was very polarizing, right? We see people either love what he did and hated what he did. My challenge with what he did is he was one physician making a decision. And I just really, I feel like if I were in that position, that's just too much power. Like, I don't want to have like one person making that decision with one patient. And that's sort of like, that's why I oppose what he did. I support the concept of self-administration, the idea that I take it myself if I'm the patient, I make the final decision. And so that's why I oppose what Jack Kevorkian was doing, because he was making those decisions on his own.
Right. You've become, Dr. Sandeen, now the face, and one of the main spokespeople of Death with Dignity. But I also know that this is personal to you. My father and I are very much aware of your story, but I would love for our listeners to really understand how you got into this field.
Yeah. I think, there's a lot of steps to my story, but I think it does go back to my mom being a hospice nurse and sitting around the kitchen table talking about death and dying. I come from a farm background, sort of like the rural middle of the United States is where I was raised. And, death and dying just seemed very real in our family, which I think is the sort of farm culture and, having a nurse first she was an oncology nurse and then she was a hospice nurse. And I sort of
even as a kid, you would talk about death? Really?
Yeah. And I sort of joked, like, it wasn't until I went to college and was at like a college party all by myself that I realized that other people don't talk about death like I do. I quickly learned, don't talk about death like that at college parties. But, so I had this different upbringing, I think, than other folks have that really normalized the concept of death. And then my husband, I got married when I was 25. And my husband was diagnosed with HIV very soon after and died. And that was in he died in 91. So that was in the fairly early days of the AIDS epidemic, and HIV was a death sentence. And it was a very bad death sentence. People died very, very badly at the time of HIV. And originally he said to me, and this is a really difficult conversation to have, but originally when he was diagnosed, he said, "You're going to have to kill me." And I was like 27 years old. Like, how do you, there's so many complications about being a widow at 27 and all of these things. But my answer was, no, I can't do that. Like, that's murder. But I had such compassion because we knew what was going to happen. Like, he was well at the moment when he was diagnosed, but, it was pretty much diagnosed. And 2 years later, he died. And that was kind of like 2 years was the lifespan at that point. And so it was really this long kind of 2 years of grappling with what his final days would be like. And the timing was such that when he was going through this process, Jack Kevorkian was driving around the country helping people die. So this issue was sort of like up in the zeitgeist. And then Oregon was considering the Death with Dignity Act. So it would be almost the first in the nation law, but almost the first in the world for the type of legislation that we have in the country. And so this was going on. He was dying. The suffering was really bad. I'm not sure in the end that John would have ever used the law. He was, if it was available in Iowa at the time, he was an incredibly religious guy, but he wanted a choice. He wanted the option. He wanted more medicine to be able to offer him more to end his suffering. And that was, that when you think about the core of some of the things that Death with Dignity is, it's about that choice. It's about, that option at the end of life. And he really wanted that. And he died without having it. And he died fairly badly. Unfortunately, the suffering was great until the very end. Although we had tremendous hospice care. And they were able to palliate most of his suffering, but not all.
Thank you for sharing that. I can imagine that image, and that experience. You carry that throughout the entire, throughout everything that you've seen. I think, like I mentioned before, this is also personal for me in a slightly different way. My grandfather had a debilitating case of Parkinson's, and he was both a U.S. citizen and a Spanish citizen. And like you mentioned, euthanasia is banned in the United States, but in Spain, it is legal. And so my grandfather, over 2 years ago, made the decision to move to Spain and to exercise that right that they do have in Spain, and to go through the process of deciding when and how he could go. In the same way that there's a very arduous process and very strict requirement process in the United States, it's the same thing in Spain, to the point that there were several medical professionals that hesitated at the beginning, and that weren't necessarily ready to take on his case, even though it was legal. And I mention that because I know that in a way that dynamic is similar in many of the countries that do have medical aid in dying, including, I believe, in the United States, because I know that in 2017, Washington, D.C., passed medical aid in dying. And if I'm correct, even a year after that, there were no terminally ill patients that had gone through the process, because there was a lack of personal medical professionals that did not have sort of the requirements to go through that process. And so I'm asking you this because how do you convince the public, how do you convince society that this choice is a legitimate one for those that are terminally ill?
I mean, that's a big question. I think philosophically, I have come to the conclusion, and a part of my career is also like teaching health policy, teaching social welfare policy. And so philosophically, like, what do laws do? What happens when we write a law and enact a law? And I really believe that culture changes before law changes. Some people think that law changes and drives cultural changes, and we could have that debate, right? Whatever. But, from my philosophy, from my standpoint, and probably on the issue of death and dying, I really believe that culture changes before law changes. And so I don't think that we see, like, it took 10 years in New York, right? Because we had to sort of like start talking about it, and physicians had to come to understand it. And so I think that one of the challenges that we face is that we have to demonstrate what dying is like. And I'm sort of like getting stuck because this is a really complicated question that you asked. But I think that for people who experience death and dying, whether it's in the United States or Spain, they experience this. They understand that modern medicine has extended our life, which is amazing. Right? Yeah. We get more time with our grandkids. We get more time to enjoy our lives. But the extra time that we get is not always good time. In fact, sometimes that extra time that we get is full of suffering. And so for me, it's not necessarily a matter of convincing people about death with dignity. Sure. It's that they experience death and dying. And the challenge is there is probably not one country that likes to talk about death and dying. We just don't want to talk about death and dying. We want this forever youth. We want to live forever. And, like the concept that we're all going to die, we just don't really talk about. And so it's not until we confront it that we're actually faced with it. But I would say, 70% of people, kind of no matter how you ask the question in the United States, support death with dignity. We see, every now and then there's a new poll, whether it's a national poll, a Gallup poll, or just like a state like New York. It's really support hovers around 70%. So people get this. They do.
Yeah. If I can add one more thing, Dad, that just because you mentioned, I think that's so interesting. This idea of what changes before. Is it culture or is it policy? And I think just bringing back my grandfather's case one more time, to your point, when a lot of his community in South Florida understood his decision to die with dignity, I think on the surface we thought that they would have this like kind of bad reaction because death is such a quote unquote taboo issue. But actually the reaction was completely different from what we had envisioned. Most people that had loved ones and, the parents that had gone through a painful death, or were terminally ill, most of them actually had a change of heart, I think, when they understood, what the real concept of medical aid in dying is. And they were like, many of them came up to my family and said, oh, I wish I would have pondered something like this for my, grandfather or for my mom. And so I think you're right that I think once you really break down what's so taboo about it, I think people do end up approaching, this issue in a very different way.
Yeah, I would agree. And I also sort of one of my fascinating things, because I straddle the political world and the patient world, like I'm a social worker, but I, hire lobbyists and work with governors and all of these things, is really where I see the controversy is in the legislature or in media headlines, right? Like in this cultural piece, but at bedside, people are at peace.
Mm-hmm.
Their families understand.
Yeah.
Like it is just so different for me that I go from this kind of, it almost feels like a toxic environment in the legislative sense to so much peace at bedside. Right. And I wish that people got to experience that. I mean, not very many people get to experience it. I do because of what I do. But that difference just really drives home for me that this is just about what happens at bedside.
Yeah, because I want to ask you if you believe that this is a human right.
I think that we have the right to self-determination related to medicine that happens to us, right? Like, in the medical field. And I think that it used to be that we had this patriarchal feeling about medicine that our doctors get to decide for us what happens to our bodies. And we have, grown to understand medicine to say, like, this should be patient-focused. This is not about some physician who went to medical school deciding for me. And so this transcends medicine for me. This moves to a human right for me.
Yeah, so I wanted to tell you that this is also personal for me because just last week, a very good friend of mine, Raúl Benoit, a great journalist, he decided to go through what he called euthanasia in Colombia. And as you know, Colombia was the first country in Latin America that approved this procedure, and then other countries just are following through the same direction. So Raúl had suffered a stroke, then he was diagnosed with Parkinson's disease, and he told me, Jorge, no puedo más. I just can't go on like this anymore. It was very emotional, very, very difficult. And then he had the procedure done in Cali, in a hospital. I wonder if this experience, not only in the United States, but in other countries, is expanding, or as you mentioned, culture is preventing it to go forward.
Yeah. I mean, I think, in my opinion, the need for something like death with dignity is created by modern medicine. And again, because we have very successful medical technologies that can extend our lives, the extra time that we get has more suffering. We die differently than our grandparents and our great-grandparents. Right? And our deaths tend to have much more suffering associated with them. And so that's why, I believe that's what created the need for death with dignity. And it's in the United States, and it's in Europe, and it's in South America, and it has to do with medicine and the human response to suffering. And what we see is the environment of politics, sort of like where it plays out in it, like it's this fight or it's this ugly them versus us. Whereas in families, it's very different, right? Around bedside, it's very different. But I think it's the politics that brings the toxicity to the issue and not the fact of dying itself.
Paula, we have to take a break and we'll be right back. Now we continue our conversation with Dr. Peg Sandeen. Paola.
Yeah, Dr. Sandeen, you've mentioned politics many times at this point, because I think that tension seems to be happening in Washington, D.C. and across state legislatures. It's inevitable that politics, and partisan politics obviously creates a barrier to what is a very human experience. And so if I take a step back, and I see that in 1994, Oregon became the first state to legalize medical aid in dying. And here we are over 30 years later, and it's now 14 jurisdictions that have medical aid in dying. I'm curious about the political strategy behind this type of coalition building that is needed to sort of move forward such a taboo issue. What have you learned in the last couple of years?
Oh, so much. Because I view this as a human rights issue, we certainly stand on the legacy of civil rights organizing in the United States as, like the learning points that we have. So I wouldn't say that in Death with Dignity, we created anything new. We learned from people who have done this before, and the civil rights movement is what I would say to begin the answer. Yeah. But I also think that the other piece that we have to conquer in terms of talking about death and dying is just the idea of the death taboo. We don't talk about death and dying in the United States. So one of the things that we have to do before we can even get to any sort of political tactics is do storytelling to break down that barrier so people can understand what it is to use language to talk about their loved ones, to do storytelling. And so we do, again, a ton of storytelling because that's how people connect, right? That's how people understand that this is a very human issue. We're all going to die. And one of the things that I think is so fascinating is once I open up a space and, if I'm leading a space and share my own story or talk about death and dying, just using everyday words, there can be a line of people who want to share their story because they haven't had either a safe enough space to do so or a room where they felt like their story would be heard or the ability to say the words ever before. And so that is one of the biggest things that we do is storytelling and create an environment for people to share stories that are very intimate. When you're talking about the death of a loved one, it is a very intimate situation. And so making sure that and again, when there's so much political rancor, how do you carve out a space to talk about death and dying? And that's probably one of the biggest things that we have to do. And I would say another of the biggest things that we have to do is we have some of the most powerful opponents that there are out there, like deep money. And so that, like how do we really go about being very politically smart about in a very tough political environment. And, and again, there's lots of lessons to be learned from other movements on that.
Dr. Sandeen, you said you have very powerful opponents, individuals and corporations. And I wonder if at some point religion is also an opponent for you.
100%.
As you know, there are many groups that oppose the concept of dying with dignity. Simply that their argument is that only God can take a life. And then with the rise of Christian nationalism, I wonder if you feel losing progress on this issue, and if at some point are you worried that the Supreme Court just might interfere with this the same way they did with Roe versus Wade?
Oh, absolutely. I think that the Supreme Court would have the ability to overturn us. So just to like a minor history lesson for our listeners, that we have death with dignity in the United States because of a Supreme Court decision in 96, that said that death with dignity is not the law of the land. It's not in the U.S. Constitution. And so that means that we have to go and win death with dignity on a state-by-state basis. So Congress could say that death with dignity is illegal across the United States, or Congress could say it's legal across the United States. So they could do both. And also the Supreme Court could say, no, you can't, the states can't have this. And so we are definitely concerned about that. I don't think that you can look at the makeup of this current Supreme Court and think that they're going to be a supporter of death with dignity. But the way death with dignity is built is that it's a medical standard of care that's codified into law, into state law. And in the United States, medicine is governed by state law. And so for the Supreme Court to change that, they would have to change medicine a little bit. And that's a big step. But we have seen that the Supreme Court is willing to take big steps, in changing things. So definitely we're concerned about that. And to your point, Jorge, about religion, I would say that the core of our opponents' opposition comes from religious points of view. And it used to be in 94, like in Oregon, it would be Catholic priests going on TV and saying they oppose this, or it would be religious figures. And what they've learned is that in the United States, they can't be the face. Religion can't always be the face of the opposition. They have to put other people as the face of the opposition. But then the money comes from religious institutions, or the money comes from powerful institutions that are impacted by religious beliefs. So I would say that 100% of our opposition comes from a religious point of view, but it doesn't always look like that. But, really, when you start to dig down and ask people questions, it does become, it's clear.
Could I ask you if you're a religious person? Does that matter? I don't know.
Yes and no. I grew up in a Baptist church. My stepson is a pastor. My mom goes to church on Wednesday nights and Sundays and probably another day a week, and sits on a funeral committee, all of the church things. But I don't go to church. So the answer is yes and no. I have a very strong grounding, but not currently practicing.
I think that, I can imagine that when you're kind of having these arguments with religious folks, that it helps, no? Being understanding that you're obviously very familiar with that world. Yeah,
it does. Well, and I would just add that one of the things that sometimes medicine has taken away from humanity, and again, medicine is given so much, but one of the things I think that it has taken away is this opportunity for spirituality at the end of our lives. Like one of the things that happens when we're dying is that we come to terms with who we are, what life was, how we lived our life, what we believe is next after we die. And those can be profoundly spiritual questions. So while I sort of engage in this political stuff that has to do with spirituality and religion and, organized religion, that's less interesting to me than how people experience their spirituality at the end of their lives. That's what's really important to me.
Yeah. And we'll get to that towards the end of the conversation, because I think that's the part that people really need to zoom into. But I would love to stay and zoom into the legislations that have been passed. What happens if you're in a state that has not passed medical aid and dying, and you want to go through this process because, say, you're covered now in a state like New York? What do you do then?
You do have the ability. There are 2 states in the United States, Vermont and Oregon, where they can prescribe to non-residents. And so if you lived, say, in Utah and you're dying, and you're close to Oregon, if you're physically able to travel to Oregon, to find 2 physicians, to go through the process, to rent an apartment here, so you have to have financial resources, then you could qualify for our law if you made it through all the steps and you qualified for all the steps. And so that's one option that you have. But again, that is based on resources. You have to have financial resources, and it is based on the quality of your health. And if you're dying, most people don't have great quality of health. So it's a burden. You think about how hard it is to move. Think about doing that when you're dying. Like that's really hard.
And that brings me to this other question, right? Like what if you are in a state that has approved this and your case isn't approved? Have you had any personal experiences, with terminally ill patients that really want this for themselves, but can't.
Yeah, I think that there's a couple of nuances to the question you asked. You sort of posited the question in the sense that somebody went to a physician and didn't qualify and went
That's
through the
right.
process and didn't qualify. So in that situation, typically what happens is, for the most part, people wait till the very end to request the prescription from their physician. You qualify when you're 6 months to terminal, but most people wait until the very end. So people who don't make it through the qualification process, they typically have very little time left in their lives and tend to go on to die from the underlying conditions. But say you have a condition like Parkinson's, where you don't qualify for the law in Oregon. So you do have an option to go to Switzerland, right? But again, that's resource dependent. You have to have the money to travel. But you have many fewer options in the United States if with a certain number of conditions that don't meet the standards. And people tend to go into hospice. They could stop eating and drinking, but that's a very complicated process, but people do it. But the reality is there are just fewer options for you.
Yeah, in that case, I mean, I'll bring my grandfather as an example. He did have a debilitating Parkinson's. Should the law in the United States attempt to cover people like them? I mean, I guess, do you think that the current state of the laws are too narrow in scope?
I don't. But I understand why people do feel that way. And it has to do with those 4 things that I talked about earlier, terminal, acting voluntarily, capable or having capacity, and self-administer. So for those 4 things to happen at the same time, there are a certain number of conditions where that can't be. Parkinson's is definitely one of them, the dementias, or Alzheimer's or another, where those 4 conditions can't all happen at the same time with certain conditions. But what I would say is that our healthcare system needs to do better about addressing those conditions. And, like one of the things that we're seeing in the United States is peeling back coverage, like health insurance coverings, peeling back what we can offer. And what we need to do is do more wraparound and really support those folks much more than we do.
Dr. Sandeen, we have just a few more questions. But I want to ask you about the families. Usually the families, when someone is dying or very ill, they want to do as much as possible to feel that they've done as much as possible to save that person. So how should we respond when someone in the family or a friend says that he wants to die with dignity? What's the role of the families?
Yeah, it's such a complicated question. And, I'm a social worker. That's who I am. I don't know if I said that earlier, but I'm a social worker at my core. And so this is a big question for me. And a couple of ways to answer that. One of the things that's interesting about Death with Dignity, when you talk to families after a patient has used the law, is almost to a person, the families say, "Oh, I'm not surprised. This is who this person is. They always knew that this is what they wanted," or "I'm totally not surprised with this choice." And so for the most part in the United States, we have family support because it just makes sense, right? It's the type of person that would use the law. But there are opponents in it. Sometimes you might have like a daughter or a son who's really opposed to that. And that really is a negotiation with that person, because it is the patient saying, "This is what I'm going to do. This is how I live my life. I've requested this, and this is what's going to happen." But frequently that person needs support, needs aftercare, needs bereavement leave to help them understand. But for the most part, it doesn't really happen very often because people say, "Oh, this totally makes sense. My father would do this." But on the flip side, if we take death with dignity out of the picture, or medical aid in dying out of the picture, we see this. I mean, just like you say, Jorge, I see people, I've worked with people who are dying, and, like the oldest daughter wants to feed mom or grandma, and mom and grandma, like it's natural to stop eating. And so it's sort of like, how do we help people understand what the natural process of dying is so that we don't sort of put our own values into what's going on with that person. And typically, if you have a family, this is the third point, I guess. If you have a family where there's a lot of conflict in general, you're going to see a lot of conflict at the end of the life. If you have a family where there's smooth and there's good communication, like that's how that person will die. That's a very frequent experience.
Yeah, if we can, I would love to stay in kind of those quiet moments, no, that those spiritual moments, like you said before. And what have you learned about the way that families say goodbye? I know you're obviously a social worker. You've been advocating for medical aid and dying for a really long time. But what have you learned about those final goodbyes?
They're so incredibly important, and there's a certain amount of universality. Again, people like, what is the meaning of my life? What is the meaning of my death? What do I want my family members or my loved ones to know about who I am or what I was in this world? People make amends if they, have amends to be made. So one of the things that's really interesting to me is the universality about dying that we have, that it looks the same in a sense. But I will say the point that I made earlier about how your family lives is sort of like how death plays out. And so I think that one of the important lessons that I have taken is like, if my family doesn't deal well with conflict, not a lot of families do, or maybe some families do, but, we can be really quiet and not really talk about it. And what it has made, experiencing other people's deaths has made me understand, like, I want to change that family dynamic now. So that when it matters in the end, we don't sort of fall into those bad practices. So I feel like understanding mortality and the gifts that people have given me by letting me be at their bedside when they die means that, what does that mean for my life and my mortality? And what it makes me want to do is be a better person. So at the end, that's what it's like.
Yeah. I can end with a personal anecdote, Dad, which is I think I learned so much, through watching my grandfather really believe in this freedom, to choose to die with dignity. And I remember to this day the way that he died that final day and this Thursday, and this summer day in Madrid. And I mentioned that because it was beautiful, to your point, because we got to say goodbye, because it was so. I mean, there was obviously I saw his courage, but it was such a beautiful goodbye. And he did it like with so much dignity and conviction. And I'm curious around what you've learned about what a good death is, through these years, now with New York happening. And what have you learned about, what the right way of dying is?
For me, a good death is one that the patient wants, right? That the patient has some amount of control. We can't always control the things that are happening to us physically. So ultimate control is, I think it's not even a concept that really exists, but, have some amount of control. But also, again, I'm just going to come back to this. Death has become so medicalized. And really, for me, the most beautiful and meaningful good deaths that I think the patients would say were good deaths were one that were about the community. And it was about their family and their friends and that small group of people that really mattered to them and the things that mattered to them, whether it was music or art or being out in nature, that those things were core to the death experience rather than being in the hospital and hooked up to, it was that medicalized, that taking the medicalization of death and bringing it back to community and family and spirituality. That's what I think a good death is.
Dr. Sandeen, thanks so much for talking to us. I didn't know how it was going to go, this conversation. Now I realize I thought it was going to be so difficult to talk about death. And somehow you made it much easier. Thank you so much.
Yes.
Yeah, thank you.
I'm so pleased to be here. Thank you.
Truly. Okay, so you are notorious for not talking about death.
Think so?
I don't think you and I have ever really approached the issue that way. In fact, I remember when my grandfather died, your dad, Gogo, The way that you told me was, I remember to this day, I was so young, but you almost, it was so fast, no? Almost like we couldn't even like process what had happened. And I think I must have been, I don't know, maybe 10 years old.
Maybe
and
10,
I think to this,
maybe 10 when he died, yeah.
When he died, yeah. And I think to this day, I've always found it, correct me if I'm wrong, that it's hard for you to really stare at this inevitable reality. So how do you feel now?
I'm not sure. Maybe it was the way I grew up in Mexico, in which in my family, I'm not talking about the rest of the families. Bueno, tenemos el Día de Muertos in Mexico, for instance, no? But you didn't talk about that. And maybe it's a generational trauma, because now that you're telling me that, remember my mom, when my grandmother died, she was only 15. And then the family was not allowed to talk about that. And I wonder if that's something that we were taught when we were kids, that you don't talk about death. And
I think that's one of the things that we learned from Dr. Sandeen, right? I think she's right in the sense that I thought it was so interesting when she said that the United States is one of the worst countries in the world in terms of how we talk about death and how uncomfortable I think American society is to approach this. And I think that really stood with me. And I think she's right.
Maybe it's the idea, Paola, that es un tabú, pero is the idea that if you talk about it, you somehow is calling it, no? And so I mean, it's always been difficult for me, especially if you're agnostic, as I am. Maybe it's something you don't want to talk about, because I don't know what's gonna happen after you die. I have no idea what happens, and maybe nothing happens. Y eso es más, aterra más todavía. So when Carlos died, tu abuelo, I was so impressed on how you handled the whole thing and how the family handled the whole thing, because it was so open. And I'm not sure if I would have the courage to go through the things that you and Los Montaner went through. No?
Yeah, and I think that's something that Dr. Sandeen also said, right? That the type of people that want this for themselves, it's a very specific type of person, no? That is so convinced that this is a right that they want, that is so convinced that they want to go through this process. I think it requires to be very clear-eyed, no, about that decision. And I remember, and I think this was one of my favorite parts of this interview, because I also lived it, which is what we never talk about. No, I think death is so politicized. It's such a taboo issue. I think we don't know how to talk about it. But I think if you put all of that to a side, when you think about the quietness of death, right, and how actually, forget about being religious, but it is it can be such a spiritual and beautiful experience, which is even weird to say out loud, but it can be. If you start thinking about it that way, and the ability, which I had, and to this day, I feel so privileged that, my family on my mom's side, that we got to say goodbye to my grandfather like that. Like, there is, to her point, there is a way to die the right way. And
in his own terms. That's what I really admire.
In your own terms.
He died
exactly.
He lived in his own terms, and he died in his own terms. That's very, very difficult to do.
It is. It's very difficult to do, but I think it's I think it's basically, and I think that was very interesting, right? Where she talked about, does culture change the policy, or does the policy change the culture? And I think perhaps there is a way to get society to understand, that there are other legitimate ways of facing death, particularly when you're terminally ill, when you have 3-4 months left of your life. Like, how do you want to spend those last months? How do you want to die in the most dignified way? And I know I can tell you in your body language, you're like, it's a weird thing.
Exactly. I'm thinking, would you do it? Would I do it? At this point, I don't have an answer. My first reaction would be no, that I would fight as much as possible to stay alive. But that's why now I realize, and I told Dr. Sandeen, this was a conversation I didn't want to have.
Yeah.
No? After watching Bad Bunny, no, this was not the conversation that I was expecting. But I'm so happy, and I wouldn't say happy, but I'm glad that we had it. No, and that doesn't mean I want to talk about death all the time, as she mentioned. No, she didn't want to go to talk to her friends about death, but it's something that we're gonna have to learn to do. I'm learning a little bit, no mucho, un poquito.
Yeah. No, yo también. Y la última cosa que digo es que, there's obviously this legislation on medical aid in dying is gaining momentum.
Mm-hmm.
I mean, there's more states that are passing it. But what also stuck with me is when I asked her, like, is this law too narrow? Like, could someone like my grandfather that had this like debilitating Parkinson, like, could people like them, should the law cover people like them?
He had to travel, right? He was in Miami. He had to travel to Madrid to do that.
Yeah, and I thought, and her answer was no. And I think I just want to make sure that we also, cover the other side of the story, which is those people that are not covered by the law. Those people that can't die with dignity here, that are terminally ill or do have other debilitating diseases. What do they do? And I think in some cases, it requires leaving the United States. And so that's, once again, when you're talking about individual liberties, I think that's why this debate is so fascinating, because it's what does it mean to die with dignity, and who's covered by that? You can have many different understandings, and I thought her answer, this resounding no, I thought was fascinating.
Yeah, so this is definitely a conversation we have to have. Una conversación que todas las familias debemos tener.
Así es. ya, respira.
Okay.
All right. You're going to live a long life, don't worry.
Vámonos, ya. Bye. Te quiero, bye.
The Moment is a production of Radio Ambulante Studios in partnership with iHeart's My Cultura podcast network. Our staff includes Daniel Alarcón, Laura Rojas Aponte, and Lisa Cerda, with help from Paola Leán, Diego Corso, Natalia Ramírez, and Elsa Liliana Ulloa. The CEO of Radio Ambulante Studios is Carolina Guerrero. Executive producers at iHeart are Leo Gomez and Arlene Santana. Pablo Cabrera, Dylan Unger, and Mark Catton also serve as producers. Sound design, final mix, and theme song by Elias Gonzalez. Our hosts are Jorge Ramos and Paola Ramos. If you like this episode, please share the word. Recommend The Moment to anyone who might enjoy unpacking these complicated times with us. If you like The Moment, pero también te gustan los podcasts en español, check out Radio Ambulante Studios. Our shows, Radio Ambulante, El Hilo, and Central are really worth a listen. I'm Miguel Santiago Colón. Thanks for listening.